TopMedTalk.
The first speaker is Carol Keane, and Carol will be working with Dr. Copeland in Sheffield, and he's going to talk about psychological screening and assessment tools for prehab.
I'm Carol. I'm a consultant physiotherapist, and I'm the clinical lead for the Active Together Cancer Prehabilitation and Rehabilitation Service, which we run in Sheffield in collaboration with Sheffield Teaching Hospitals, Sheffield Hallam University, and with funding from Yorkshire Cancer Research. We've been up and running since February of last year, so just over a year now, and we've had over 500 referrals into the service. I'm going to be talking today about psychological screening and assessment in prehabilitation, its importance and how it's used. I'm going to be drawing on some of the work that was done in terms of bringing together guidelines and recommendations by the group brought together by Macmillan, Royal College of Anaesthetists and the National Institute of Healthcare Research. And I'm also going to bring in some of the things that we've seen and observed and found through our last year or so in running the Active Together service and bring that all together for you. So in the UK, at any point in time, it's estimated that 1 in 6 people is experiencing some psychological ill health. That might be from the more common anxiety and depression or from more serious mental health problems. If you add on to that a cancer diagnosis and the experience of going through treatment for cancer, then it's easy to see how those underlying conditions could be worsened or exacerbated. Somebody who experiences anxiety and it impacts on their life, who now has a new serious diagnosis, who has the worry about treatment and planning and the potential outcomes from that treatment. Somebody with disordered eating who now has swallow problems because their tumour's obstructing their esophagus. Someone with previous suicidal thoughts or risks who now has a diagnosis that is potentially terminal, life-shortening. Somebody who's on medication for psychosis who now has to incorporate into their regime medications around chemotherapy or treatment for their cancer. So you can see how that pre-existing risk might be heightened and exacerbated by cancer, and then also bring into that patients who perhaps didn't have psychological problems that impacted on their lives before, who then begin to present symptomatically because of their new cancer diagnosis. I'm going to do that. So out of all of that, we find that between 30 and 40% of patients being treated for cancer will experience some psychological ill health at some point during their treatment. And that's important for us in prehabilitation because we need to know and understand that. We need to support patients to manage that. But also because psychological risk is a factor that influences outcomes in getting through treatment, in getting through surgery. So patients with higher levels of anxiety, with more psychological ill health, patients with lower self-efficacy are more likely to experience worse pain, for example, wound healing, length of stay. All of the things that we're trying to ameliorate or improve through our prehabilitation. All of the things that we're thinking we might be measured on if we're going to demonstrate the success of our prehabilitation. So it's important that we understand and address psychological concerns and get that as right as we can for patients as they go through prehab. And it's not just that. I always think of multimodal prehabilitation as something like a 3-legged stool. Psychological well-being, physical support, dietetic support. You have to have all of them in there equally. Patients can't engage with one if the rest of it isn't well balanced. You need that good tripod, that pyramid in there. If somebody is being overwhelmed by their psychological concerns, by how they are, they're really, really going to struggle to take on board the messaging around nutrition support. And think about it day to day. If you're in a really bad way, if your mood is low, if you're very anxious about something, you're more or less likely to go to the gym, aren't you? You're more or less likely to shop well, prepare a healthy meal, plan your food for the week. And so all of these things are intertwined. You cannot address one without addressing the other. So if we want to make improvements in people's physical health, in their dietetic well-being, we need to address their psychological support as well. So the recommendation is that patients are screened and assessed for psychological well-being at the outpoint of their prehabilitation. And what that first of all does is it lets us identify the level of risk. And Mike earlier showed this triangle slide, which is in the Macmillan guidelines, which talks about having a small number of patients with specialist needs, our targeted patients, and then that wider universal base of patients. If we screen and assess for their psychological level of need, we can identify which of those 3 tiers the patient sits in, and we can therefore meet their needs appropriately. We can therefore make sure that they're getting the level of support that they need to support their problems and their psychological well-being. Assessment and screening is also important to monitor check risk over time. It would be very naive, wouldn't it, to think that how a patient is on the day that they first come along to your clinic is how they're going to be throughout the rest of their prehabilitation, rehabilitation pathway. So monitoring patients' needs as they change and keeping an eye on that, having a good baseline measurement so we know how they were when we started, means that we can respond to any changing needs that we see. And finally, I think identifying level of need and screening and assessment and their role in that is really important in us managing our resource usage. It's going to be scarce, isn't it? We're not going to have a whole lot. We haven't got a blank checkbook to do this. So if we can find those patients at most risk who need high-level specialist support from very skilled staff and target them towards that, then we can allocate our resources accordingly and we can make our service as cost-effective as it can be. In terms of tools that we can use for screening, it starts to become a bit less clear-cut about what the right things are. And again, I think this sort of taps into some of what Mike said earlier about some of the questions that still need to be answered in prehabilitation. So we ran a workshop last summer where we had 8 different centres with established prehabilitation services coming into the workshop. And as part of that, we polled everybody on the outcomes that they use. And as you can see, it's quite mixed and not universal. There's less agreement than you might think. And it's only a small sample, obviously. So people are using a range of tools. They're primarily assessing depression and anxiety or a combination of both. And also, we found that while everybody was screening for some form of physical outcome, that coverage for psychological outcomes was less universal. And then also when we look at those measures which are slightly more related to psychological well-being, but not so directly, like fatigue, quality of life, again, we find a range of different measures being used, although there is a bit of agreement around EQ5D for quality of life on that. So what tools to use to assess? Maybe it might be something that you might need to think of as a service, maybe something that we might have guidelines on further down the line. What we do in Sheffield and what we do in our Active Together service, as an example for you, is we use a composite scoring tool. So we use the GAD-7 as a measure of anxiety. We use PHQ-9 as a measure of depression. We also ask patients if they're currently being treated for any existing mental health conditions and if they've been treated in the past for any mental health conditions. And then we do use an element of clinician judgment. All of our patients are seen face-to-face in their first assessment. And so there is the opportunity there for the clinician who is seeing the patient to determine whether they think that on presentation, the patient maybe appears to be higher risk than they did in the screening questionnaires that they completed beforehand. There are patients who struggle to complete the questionnaires, who don't understand the nature of the questions, or maybe if they're completing them with a family member in the room or something like that, they might not put the answer as they might entirely feel it to be. So we have that sort of like clinician override in there, which we can use if we need to. And then through that, we use a little simple algorithm to create a score to identify if patients are specialist, targeted, or universal. And what we have found through our last year or so of patients, and I think this relates to about just over 300 patients, is we don't quite have a pyramid. We don't quite have a triangle. So the data shows us that, yes, we do have that nice broad universal base of patients who are coming in at low level of need and low level of risk. But in our scoring, we're a wee bit upside down with our specialists and our targeted, where we're getting more patients into that specialist bracket. So that has questions for us, doesn't it, in terms of why? Is that because, are we post-COVID? Are we seeing more patients with higher level of anxiety? Are there other things going on there? Is it something to do with our algorithm? And as a now more mature service, being up and running for a year, is it time for us to go back and look at our data, tweak our algorithm a little bit? Or is that just actually how it is? Is that actually how it's presenting to us? Is that what's out there and what's in there? And so we need to respond to that accordingly. There's no point screening and assessing for psychological level of need and risk if we can't do something about it. And that the recommendation is that those patients who come up in that highest level of scoring of risk and need, need to be very, very carefully monitored and may need to be signposted or referred to or given support through psychological therapists. Like those of you, I'm sure I talk to a lot of other people running prehab services or thinking about setting one up, and often access to clinical psychology is a real concern for people. And I think it's really, really important that we bear in mind that where there is a role definitely for clinical psychology in supporting some of these patients in high need, there are also many, many, many ways that we can offer psychological support to patients going through prehabilitation. We, as well as signposting those more complex patients, we run, for example, wellbeing workshops where we teach tools and techniques, relaxation techniques, breathing, coming to terms with the anxiety that the patient have. All of the staff in our service are trained to provide level 2 psychological support as defined by NICE, the National Institute for Clinical Excellence, so that every conversation that the patient's having with a team member is landing with somebody who can have an understanding of the issues that they might be going on with, who can provide that first level of supportive, empathetic conversation, who can identify those patients who are most at risk and need moving on somewhere else. If we get our physical activity support right, if we get our dietetic support right, we can see people moving forward from a psychological wellbeing point of view. Mike mentioned earlier, didn't he, individualised and personalised care, approaching patients with a question that deals with what matters to you and asking them what's most important to them and helping them to work towards goals and achieve goals that matter and important to them, seeing the steps that they've taken along the way, seeing the progress that they've made. Again, it's not psychological therapy, but it helps patients to improve their well-being and to feel better for it. And then we have behaviour change techniques, our motivational interviewing techniques, that again, good listening and empathetic here, helping people to improve their self-efficacy and that self-management, that empowerment and feeling of control. So although there is a role for clinical psychology, there are so many other things that can be going on in your prehab service that can support in that way. And it was, again, talked about earlier, but never underestimating the power of peer support, allowing patients to work together, to work in groups, for people who've been through cancer treatment, to support patients who are going through cancer treatment, for patients and their carers, the people near to them, to share experience and to have other people going through the same thing that they can talk to, are all ways that we can help our patients move forward. So again, drawing from our data and looking at how we've been getting on with this, if you like, in our Active Together service, what we've got here is outcomes from our screening scores at different time points, where T1 is the initial assessment, T2 is the end of prehab, and we are a rehab service as well, so reassess everybody at the end of their treatment and again at the end of their rehabilitation, which is normally about 3 months afterwards. And what we can see is that patients see a marked improvement in their psychological well-being between initial assessment and end of prehabilitation. We see things worsening again as they go through treatment, and then we see them improving again as they go through rehabilitation, which speaks to the value that good prehabilitation can give to improving people's psychological support and well-being. Also shows how much, even with that improvement, how much impact treatment can have on people. I know that prehabilitation is important. We talked about that continuum of care. I think to sort of leave people there without the rehabilitation support where we can continue that learning, that improvement and that change with them is important as well. So that's me for now. Brief overview of where psychological health and prehabilitation fit together, of how screening and assessment can be used to support patients and identify the need that they have, and then just how we can use a different range of interventions to bring that together and help patients to improve. Thank you very much.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.